Hello everyone. Today we will be talking about national health programs in India regarding various diseases. First, before going into the topic, I have written few bullet points so that you can revise the entire topic after going through the video. Please kindly check the bullet points so that the entire topic will be revised within no time. Now, what are national health programs and why they are needed to be implemented in India? You all know health is a basic concept that every individual in the society need to take care of. See, when a particular group of persons or a large group of persons in the society are affected with a particular type of a disease, then there will be a condition or situation like to prevent it or to cure the disease. In some cases, there will be emergency situations we need to look after immediately in order to prevent or eradicate it from the society. In such conditions, these national health programs come into the picture. By whom these are implemented? Actually, national health programs are implemented by central government of India with the help of international agencies like WHO, UNICEF or SIDA, Swedish International Development, things like. Now, if you look at this, why NHPs are introduced and what is the need of this? Why they are introduced? Simple, to control or to eradicate communicable diseases, or you can also quote like controlling the population or improving the immunity in the society, or every health related aspect in the society are examined and clarified. You have to think in such a way so that it will be easy for you to read about the national health programs and also to memorize it. Now, if you look at, today we will be discussing about tuberculosis. National health programs on tuberculosis. Okay? Before going into the national health programs, first of all, let us recall in a brief manner about tuberculosis. You all know it is a disease which is caused by Mycobacterium tuberculosis. You also know it is transmitted by what? It is transmitted through air in majority of the cases, through the droplets of saliva. The bacterium resides in it and infects the other person. Do you know that a person who is infected with Mycobacterium tuberculosis is capable of infecting to 10 to 15 persons in a year? The single person is capable of transmitting to the other persons, like 10 to 15 persons in the society, if he is not treated well. So it's like a major issue we need to look after. And also, I want to tell you that in the year 1983, there is a global emergency in India with regard to tuberculosis. You can also think, when global emergency has occurred means a large number of people have been affected with this disease. So, like a basic question comes to your mind. So, are there not any national health programs regarding to this disease? Yes, they do exist. Primarily, we'll discuss with two national programs. First thing is NTP, National Tuberculosis Program, in the year 1962. Whereas the second thing is like Revised National Tuberculosis Control Program, which we term it as like RNTCP, in the year 1992. We'll be discussing exclusively about these two programs in this presentation. Now, what is NTP in the year 1962? See, in the year 1962, Government of India introduced a program, National Tuberculosis Program, but it became like a sign of a failure. Why? Why it became a sign of a failure? See, in those days, awareness on the health is not like today. So definitely the programs may not reach each and every person like how it is reaching today. This National Tuberculosis Program, which I am talking about, NTP 1962, is a sign of a failure. Why? First thing, the number of cases that are being affected increasing day by day. It's not been reduced due to this program, and also the morbidity and mortality rate have been increased. There is a gradual increase in number of these two parameters. The major hurdle for this program is like persons are developing resistance to the drugs, which is a major threat in case of NTP. So the government of India, with the alliance of WHO, UNICEF, and also SIDA, they have introduced RNTCP in the year 1992. Then things become to change then after. What happened this RNTCP? If you can closely look at the relative parameters, if you can compare the both, you can clearly understand what are these programs. If you can look at the NTP and RNTCP simultaneously, what are the objectives? If you look here, the objective is to diagnosing and treating. Just we have to diagnose who is affected and treating. Whereas here, the objective is to break the chain of transmission. It really plays a crucial role in the eradication of the disease. Whereas coming to the operational targets, like what are the operational targets? There is no specific target for NTP. Whereas coming to RNTCP, there is a specific target. They have targeted like, the cure percentage should be greater than 90%, and the case finding, we have to find how many number of cases are existing in that particular type of locality. Overall India. Why I am talking about particular type of a locality means, though the RNTCP program have been introduced in the year 1992 to 1993, it was officially launched in the year 1997. Why? It took a lot of years to reach each and every part of the country. You know that? That's why I'm talking about RNTCP 1992. Though I wrote that, officially it was launched in the year 1996 to 1997. If you look at the third one, strategy. What strategy they play? Simply, NTP played like, conventional treatment. They have simply gone with the regular treatment that have been for tuberculosis. Whereas RNTCP, they majorly concentrated on two parts. One is DOTS therapy. And the second thing, which is really important in the strategy of RNTCP, is uninterrupted drug supply from the government. And the final one, diagnosis. If you look at the diagnosis in case of NTP, it majorly based on X-rays. Whereas in RNTCP, it is not based on X-ray, but it is based on microscopy, sputum smear microscopy, which is an enhanced thing, which is an accurate thing in the diagnosis of tuberculosis. Now, we have compared the two programs, right? Now let us look at RNTCP, like what is the history of RNTCP? I already told you what? It was introduced in the year 1992, though officially launched in the year 1997, so that it is reached to each and every part of the country. In 2006, 24th March, every part of the India is with DOTS therapy. The strategy which RNTCP have been introduced, every part of India is using the DOTS therapy in order to treat tuberculosis. It was officially given by the government. You have to look, not just history, the infrastructure. What made the government to achieve this? There should be a particular infrastructure for sure. For each and every 1 lakh people, I'm repeating again, for each and every 1 lakh people in the country, there is a microscopy center. There is one microscopy center. Suppose if it is hilly areas or mountainous areas, for each and every 50,000 people, there is one microscopy center. And for every 5 microscopy center, there will be one supervisor who will be monitoring TB cases. So you can think Okay, the infrastructure is going good. So for every 5 lakh people, there is one supervisor who will supervise all the positive cases. Positive cases, I mean to say what? Sputum smear positive cases I mean to talk about. Okay, now diagnosis. How the diagnosis have been going on? I already told you what is the major part of diagnosis in case of RNTCP. What? Sputum smear microscopy. How this diagnosis been carried out? You have to think like Gill-Nielsen staining technique. What is this Gill-Nielsen staining technique and how the diagnosis, the sputum smear diagnosis, how it will carry on? For example, there is a person who is infected with TB, who is having a productive cough for greater than 2 weeks, who is having fever for greater than 2 weeks, who is with weight loss, who have been complaining of loss of appetite. These symptoms majorly contribute to go to the sputum smear microscopy test. What they'll do, as soon as the patient comes on the spot, they'll take one sample, sputum sample. The next day morning, immediately after coming, they'll take the second sample. They'll take these 2 samples and they will examine it and they will conclude it, whether if it is positive, if it is negative. Remember one thing, in either of the 2 samples, one is positive, we'll conclude it like the person is positive, the person is infected with tuberculosis. Just remember that point in case of diagnosis part. Okay, now Gill-Nielsen staining technique is a staining technique which will be involving certain steps. There is no need to discuss much about it, but I'll just say a few lines so that you can go to the other videos so that you can recollect it. So this Gill-Nielsen staining will be using hydrochloric acid and also methylene blue, and some other techniques will be used for staining the mycobacterium, and finally we'll conclude it whether the person is infected with TB or not. That's how the diagnosis part takes place in case of RNTCP sputum smear microscopy test. Now we have to look at treatment part. See, this is a really very important. Why? Because I have mentioned the table over here so that you can pause the video or you can take the screenshot or you can take the notes of it. This is the standard regimen which is followed by WHO, so no need to doubt anything about it. Why I have mentioned it so that it will be easy for you to revise it. Okay, there will be 4 categories in the treatment. We'll divide the patient into 4 categories. The category 1, the category 2, there will be the category 4 which we'll generally call it as like resistant people. Category 5 resistant people will call it as. In category 1, what will happen? The newly positive cases, the person who acquires the new cases, like he was infected with new, it was the first time for him to be infected with TB. Those comes under category 1. Generally in category 1, we'll have 4 drugs in the treatment. Generally I'm talking about, we'll have, see, H for isoniazid, rifampicin, pyrazinamide and ethambutol. So in the category 1, isoniazid, rifampicin, pyrazinamide, ethambutol. There will be 2 phases in case of treatment. What is this about 2 phases? I told you in the starting. What? There is DOTS therapy, which is the strategy of RNTCP. What is this DOTS therapy? Directly observe treatment short course. See, in this DOT therapy, the person will be directly observed. The patient who is infected with TB will be directly observed during the management. The treatment will be of 2 phases, initial phase and the continuation phase. In the initial phase, he will be given a blister packet of drugs for 1 day, whereas in the continuation phase, he will be given a blister packet of drugs for 1 week. Okay, initial phase for 1 day and the final phase, continuation phase for 1 week. Again, he need to change every week, like that it need to be happen. Like you can also think there is a system in this DOTS therapy. Remember that 1 week completion, like 1 week he completed using all the drugs. The next week, in order he have to take the drugs, what he need to do? He has to show the empty blister packet of drugs to the pharmacist. Then only he will give the fresh packet of drugs. Like that, the process has been implemented in case of DOTS therapy, so that it is a successful regimen type. Okay. Now, in case of category 1, the total duration of the treatment will be 6 months, okay, whereas 2 months in the initial phase, 4 months in the continuation phase. In the initial phase, there are 4 drugs that we generally give: isoniazid, rifampicin, ethambutol, and pyrazinamide, which is referred to Z over here. It is given in alternate days in a week. So see, this 3 number is like 3 times in a week for 2 months. I am saying it for your understanding, okay? Similarly here, in the continuation phase, the coming 4 months, 3 times a week for 4 months. What are these drugs? Isoniazid and rifampicin. Total duration is 6 months. Similarly, in case of category 2, who is category 2? The patients generally with relapsed disease are category 2 patients. In that, the duration will be like 8 months. If you can look over here, the duration changed when compared to category 1 people. Category 2 people, total duration of treatment is 8 months, which includes 3 months of initial phase and 5 months of continuation phase. In the 3 months of initial phase, again it has been divided into 2 months and 1 month. In the 2 months, all the 4 drugs are repeated, plus streptomycin have been added twice a week. I mean like thrice a week. Whereas the next coming week, the 4 drugs are repeated as like category 1. Coming to continuation phase, similarly, HRE, ethambutol is added. If you compare with category 1, here ethambutol is added. Similarly, thrice a week for 5 months. This is category 2. Now, these 2 are really important, category 4 and category 5. Why I am stressing these are really important? Simple. I told you in the early, what is the major hurdle that NTP faced? Resistance. These 2 talk about resistance. MDR, multi-drug resistant tuberculosis. XDR, extensive drug resistant tuberculosis. What is this multi-drug resistant tuberculosis? Who are the people with multi-drug resistant tuberculosis? Simple. The patients with resistance of isoniazid and rifampicin, they come under MDR. The patients with isoniazid, rifampicin and any drug of quinolone family and some injectables of the second line therapy like kanamycin, amikacin, etc. All these who are resistant, those come under extensive drug therapy. You need to remember these 2. What are the primary difference between these 2? Coming to the treatment part, I'll just say out the drugs so that you can note it down, no problem. The duration will be like 18 to 24 months over here, and this is 24 to 32 months total duration, in which initial phase includes 6 to 9 months in case of MDR, 6 to 12 months in case of category 5 XDR. Continuation phase includes 12 to 18 months in case of MDR, 18 months in case of XDR. What are these drugs? Because these are other than isoniazid, rifampicin, right? Just look at the drugs. It's very simple. See, kanamycin, levofloxacin, pyrazinamide, ethambutol, ethionamide, cycloserine. This is again levofloxacin, cycloserine, ethambutol, ethionamide. Similarly here, HH means what? High dose of isoniazid. Okay, remember it. It's really important. Capreomycin, clofazimide, linezolid, amoxiclav, moxifloxacin, P includes para-aminosalicylate. Similarly, these things. So we have to see what are the different type of regimens for drug resistant tuberculosis. So this is the end of the treatment part over here. Now you have to think, when you are reading national health programs, just remember one thing. What are the programs? This is like conclusion part, okay? what are the programs we have read, what are the objectives, what is the strategy of the program, what are the diagnostic parts like we have included, what are the treatment regimen that have been changed when compared to the previous programs. If you look all such parameters, the entire topic will be revised very easily. Thank you. Have a good day.